Good morning, everybody. This is Dr. Robin Koidara. I'm going to present on sepsis and SARS. I've taken the slides from Dr. Silas Marzan, so please thank him for the work he's done. Shall we begin? I hope you guys are safe and sound in wherever you are. Please maintain social distancing. Okay, shock is a systemic state of low tissue perfusion with impaired cellular metabolism manifesting with severe pathophysiological abnormalities. So basically, shock is when the perfusion is not able to take care of the cellular metabolic needs, whereby supplying the food that it requires and washing away the waste that it creates is not possible. An infection is an injurious contamination of body or parts of a body by agents such as bacteria, virus, fungus, or protozoans, or by the toxins they have produced. And bacteremia is defined as the presence of bacteria in the bloodstream. SIRS, or systemic inflammatory response syndrome, is diagnosed when there are two or more of the following, where the body temperature is more than 38 degrees or less than 36 degrees Celsius, the heart rate is more than 90 beats per minute, the respiratory rate is more than 20 per minute, or a carbon dioxide level of less than 32 millimeters of mercury, when there is increased or decreased white blood cells count of 12,000, more than that or less than 4,000, or when there is a increased immature gland cells of neutrophils that is more than 10% of the total. When there is hypotension that is persistent despite adequate fluid resuscitation, that is defined as septic shock. And when there is failure of more than one organ system that requires intervention for homeostasis to be maintained, it is called multi-organ dysfunction syndrome. Sepsis is SIRS plus documented or suspected infection. Severe sepsis or sepsis syndrome is sepsis plus one or more than one organ failure. For example, ARDS, respiratory failure, CVS, hypotension, acute tubular necrosis, AKI or renal failure, or CNS abnormalities. So this is a stepwise process, but it's difficult to determine which step you are in. You know, it's a part of a continuum, even though the definition quantify it into different subgroups. So there is SIRS, then sepsis. SIRS, remember, two or more of the criteria of temperature, respiratory rate, heart rate, WBC count. Sepsis, when confirmed or suspected infection plus SIRS. Severe sepsis, when there is SIRS plus confirmed or suspected infection with hypotension of less than systemic blood pressure of less than 90 millimeters of mercury, or lactate levels in an ABG of more than 4 millimoles. Septic shock, severe sepsis with persistent signs of end organ damage, hypotension, and lactate levels are high. Now, sepsis and septic shock, basically bacteria with exo and endotoxins in blood. When blood has live bacteria, it's called bacteremia. There is an immune response to the exo and the endotoxins and the bacteremia, and these are at the different levels, and this leads to the circulatory cytokine cascades and systemic inflammation that ensues, which leads to different complicated responses that have, like for example, release of IL-2 leads to fever, then release of nitroxide from those causes vasodilatation. Therefore, in endotoxemia, there is peripheral vasodilatation, so patient is hypotensive, but Initial phase, warm periphery. When there is hypotension that is sustained, then there is contraction of the peripheral vasculature and therefore cold periphery. Okay. The whole point of this is inadequate circulation, therefore tissue hypoxia. So the common presentation is as SIRS is defined: fever, increased heart rate, increasing respiratory rate, hypotension, oliguria or anuria, and confusion. There may also be symptoms related to a specific infection. For example, patients with cough, pneumonia, and painful burning micturition, increased frequency of micturition with, for example, a kidney infection, pyelonephritis, ascending UTI. Now, in the very young and the old, and people who have a weakened immune system or are on immunosuppressives, they may not have symptoms of a specific infection, and their common presentation may also have, may not present with all the common things. So etiology, most commonly bacterial, but maybe fungal or viral. Before the age of antibiotics, in the pre-antibiotic era, gram-positive bacteria were the primary cause of sepsis. After introduction of antibiotics in the 60s to the late 80s, gram-negative bacteria became the predominant cause of sepsis. After 1980s, gram-positive bacteria, most commonly Staphylococcus, are now considered to be the primary cause of sepsis in more than half the cases. Other common bacteria include Streptococci, E. coli, P. aeruginosa, and Klebsiella. Usually in patients who are hospital acquired, who have had abdominal surgeries, this gram-negative sepsis is more common. In patients in ICU for a long period of time, fungal sepsis accounts for about 5% of the severe sepsis and septic shock cases. The most common cause is obviously Candida, which is frequently a hospital acquired infection. So common sites of infection: the lungs, which is about half the cases. That's followed by the abdomen and the urinary tract. And in almost 1/3 of the patients, the source of infection is unclear. So basic principles of management is that resuscitate the patient, give antibiotics, remove the cause, supportive treatment, and nutrition. So initial resuscitation, sepsis and septic shock, these are medical emergencies. And treatment and resuscitation should begin immediately. You should give a loading dose of about 20 to 30 ml per kg body weight of IV crystalloids within the first 3 hours. Additional fluids should be guided after frequently reassessing the patient of the patient's hemodynamic stability, status, and the patient's hydration status. The reassessment is done through a clinical examination, for example, heart rate and physiological variables like heart rate, respiratory rate, the blood pressure. If you have inserted a CVP insertion to see the CVP level and arterial oxygen level by doing a ABG, a temperature, urine output, and serum lactate levels. Crystalloids are the fluid of choice for initial resuscitation and subsequent intravascular volume replacement. If the patients require multiple episodes of and substantial amount of crystalloids, then colloids like albumin, exastarch, and gelatins can be added, especially when the patients have cardiac condition which does not allow a lot of fluid to be given. The goals of an initial resuscitation is to keep a CVP of in between 8 to 12 millimeters of mercury, a mean arterial pressure of about 65 millimeters of mercury, and a urine output which should at least be more than or equal to 0.5 milliliters per kg per hour, and a central venous oxygen saturation of 70% or more. Now, you should initially take an appropriate microbiological cultures before starting antimicrobial therapy. Samples like pus, swabs, blood cultures, cerebrospinal fluid, urine, respiratory secretions, and other body fluids, catheter tips, and CVP tips. These are especially useful in patients who have been in an ICU setting or post-operative patients who have been sick for a long period of time, and therefore you're taking out the CVP and catheter tips because of the fever. Now, blood culture is almost always a must because In sepsis, usually blood is contaminated with the microbiome. Now, pus swab, cerebrospinal fluid, and urine, these are part of the workup for sepsis, and specifically when one area, one site is deemed suspicious for the source of sepsis. Now, if we could wait for the culture reports, then we could start the proper antibiotics, but in sepsis, that substantial delay is not acceptable. So after taking the samples, you have to start IV antibiotics immediately. So they should be initiated as soon as possible within recognition, after recognition, and within 1 hour for both sepsis and septic shock. And the mode of delivery of antibiotics, intravenous more than intramuscular, and sometimes if it's not feasible, then intraosseous. Oral antibiotics should not be given in patients with suspected sepsis and septic shock. The antibiotics should be empirical because you don't have your cultures yet. They should be broad spectrum with most usually at least 2 microbials which are synergistic or complementary to each other, so they can cover all the likely pathogens. Combination therapy should not be used routinely in absence of shock. Combination therapy not be used for routine treatment of neutropenic sepsis and bacteremia. Empirical therapy is narrowed to sensitive antimicrobials once the pathogen is identified and sensitivities are established. The dosing should be optimized by seeing the pharmacokinetic and the pharmacodynamic principles, and a larger dose as far as feasible should be given. And they should be given for at least 7 to 10 days for most serious infections associated with sepsis and septic shock. A procalcitonin serum procalcitonin level can be used to shorten the duration of therapy sometimes. Now, procalcitonin levels in sepsis tends to correlate with the mortality and morbidity of the patient. Therefore, serum procalcitonin levels are also routinely sent in ICU setups for patients with sepsis to find out about their prognosis. Sustained systemic antimicrobial prophylaxis in severe inflammatory states of non-infectious origin, for example, severe pancreatitis and burn injury, is not recommended. Factors determining the appropriate antimicrobial regimen is the anatomical site of infection, so that you have a suspicion of the kind of bacteria, the pathogen that you are dealing with. Also, the typical antimicrobials that are able to penetrate and be available at that site. Prevalent pathogens in the community, hospital and a hospital ward. For this, we need a strong infection control unit, and we need data from the hospital to know that what bacteria, viruses, or fungus are there, and the antibiotic profiles, sensitivity profiles of those, and the resistance patterns of the prevalent pathogens should be known to the doctors who are treating these patients. We also need to take into account the specific immune defects, for example, neutropenia, if the patient has had a splenectomy, or the patient has a poorly controlled HIV infection, is the patient under immunosuppression for, let's say, for example, a renal transplant, and the age of the patient, especially the extremes, and comorbid of the patient, for example, diabetes, liver failure, renal failure, have to be taken into account. Now, second important thing the third important thing after sending the samples and resuscitation, starting antibiotics, is source control. You must identify and control the source as rapidly as possible, because it will be a nidus for infection. For example, incision and drainage of an abscess, debridement of an infected necrotic tissue, removal of a potential infected device. A surgical intervention is required, for example, in an intra-abdominal abscesses, GI perforation, ischemic bowel or volvulus, cholangitis, appendicitis, polycystitis, pyelonephritis, necrotizing soft tissue infections, deep space infections, for example, in empyema, in septic arthritis. So we have to identify the source of the infection and see. For example, in cholangitis, surgery used to be the mainstay, but these days no longer. What do we do now? We do a ERCP and a stenting so that the bile stasis is no longer there. And you also take a bile sample for a culture. In cholecystitis, surgery. If the patient is very sick, cholecystostomy, percutaneous drainage. In a pyelonephritis or a pyelonephrosis, usually not in pyelonephritis, but in pyelonephrosis, you need to do a percutaneous nephrostomy. For blood pressure, maintaining blood pressure, vasoactive agents are used. Noradrenaline is the first choice. Dopamine is an alternative, but in patients where low risk of tachyarrhythmias and absolute or relative bradycardia are there, because dopamine tends to cause tachycardia. Dopamine is used as a second line to show persistent hypoperfusion despite adequate fluid loading and use of agents. When the adequate fluid restriction and vascular therapy are not able to restore the hemodynamic stability, IV steroids in the form of hydrocortisone of 200 mg per day is recommended. This is like 2016. Hemoglobin blood transfusion usually for anemia that's causing only when the hemoglobin is less than 7, or if the patient has got multiple comorbidities, therefore the patient is unlikely to bear anemia. Prophylactic platelet transfusion when the counts are less than 10,000 per millimeter cube. If there is no bleeding or less than 20,000, insignificant risk of bleeding. In patients with higher counts like 50,000, more than 50,000, their platelet transfusion should only be advised for active bleeding if surgery is required or you are performing an invasive procedure. Erythropoietin here in treatment of anemia in sepsis is not recommended because it does not get the time to act. You are dealing with an urgent situation. To fresh frozen plasma to correct clotting abnormalities in the absence of bleeding or planned invasive procedures is not recommendation. There is no recommendation of using IV immunoglobulins, blood purification techniques, anticoagulants like antithrombin and thrombomoduline or heparin. Mechanical ventilation. Patients who have respiratory failure are put in mechanical ventilation, and higher peak is preferred over lower peak, lower tidal volumes over higher tidal volumes, and head of the bed is elevated between 30 to 45 degrees to limit aspiration risk and to prevent the development of ventilator associated pneumonia or BAP. Prone over supine position in adults with sepsis induced ARDS because that frees up lung more when the PaO2 divided by FiO2 is less than 150. Neuromuscular blocking agents should be used for as low as possible, less than 48 hours for sepsis-induced ARDS, and when the PaO2 to FiO2 ratio is less than 150. High-frequency oscillatory ventilation is not recommended in adults with sepsis-induced ARDS because in these patients, HFOB is associated with increased source of bacteremia and septicemia. Beta-2 agonist for treatment of sepsis-induced ARDS is also not indicated unless the patient has bronchospasm because they tend to cause hypotension. Sugar control is important in these septic patients. There is a relative insulin resistance. Now, you should commence insulin therapy for control of sugar when there are 2 consecutive samples that are more than 180 milligrams per deciliter. The target is not absolute sugar control, but to maintain between 110 to 180. Slightly higher sugar controls are not associated with increased level of infection. Now, you have to initially monitor the glucose levels every 1 to 2 hours till you stabilize the infusion of insulin. After that, every 4 hours, if the patient is receiving insulin infusions. Now, arterial samples are better to see glucose levels compared to venous samples. and the capillary samples are the worst. If there is AKI because of the sepsis or renal failure associated with the complications, we need to have a renal replacement therapy. And bicarbonates are not recommended until the hypoperfusion and lactic acidemia decreases the pH to levels below 7.15. Now, in patients who are immobile because of sepsis, then fractionated heparin and low molecular weight heparin against venous thrombosis is advised unless it is contraindicated for various reasons like increased chances of bleeding, and low molecular weight heparin are preferred to unfractionated heparin. Combination of pharmacological and mechanical prophylaxis whenever possible, for example, using stockings, using intermittent compression devices, mechanical prophylactic devices when the pharmacological devices, prophylactical medicines like low molecular weight heparin are contraindicated in patients. These patients tend to have stress ulcers, so the patients are recommended to have PPI only when there are risk factors for GI ulcers. If there are no risk, if we recommend PPI, they tend to lead to increased ventilatory associated pneumonia, because when there is no acid, the stomach gets rapidly colonized with bacteria. In patients where there is a risk of GI bleed or where they have developed stress ulcers, then PPIs or histamine 2 receptor agonists are indicated. Nutrition is very important. We must initiate nutrition as soon as possible, if feasible interval. If not, initiate IV glucose and advanced interval feeds as tolerated over the first 7 days. Post pyloric feeding tubes placement with feeding intolerance or who are at high risk of aspiration. See, remember, ventilatory VAP is very common in patients where ICU are inserted, very common in patients when patients are unconscious. Therefore, we give ventilation with frequent levels, the bed treated at 30 to 45 degrees. So, if there might be gastric stasis and aspiration, therefore, it is better to put in a post-pyloric feeding tube placement and interval feeding. Early parenteral nutrition alone or parenteral nutrition in combination with interval feedings is not recommended. These patients usually parenteral nutrition is commenced if the patient has not had enough to eat for 7 days. So in the first phase of sepsis, we try not to give parenteral nutrition. If the patient is not able to tolerate the feed, then prokinetic drugs like metoclopramide, domperidone, and erythromycin are used. If because the cause of sepsis is GI and the patient is not able to take interval nutrition for a prolonged period of time, then total parenteral nutrition is instituted. So what are the goals that we want to set? Remember, counseling, prognosticating, and discussing with the patients and families is a must. Patients with sepsis and multi-organ system failure have high mortality rate. Many will not survive or will have a very poor quality of life. Goals of care should be incorporated into the treatment and end-of-life care planning, utilizing palliative care principles wherever they are appropriate. For example, very sick patients with a lot of comorbidities, patients with terminal illnesses who are in sepsis, we must impress upon the relatives that sometimes we are just trying to prolong the ICU stay of the patient without a very good chance that the patient will survive and lead a decent, productive life outside. In such cases, non-beneficial ICU advanced life product treatment is not consistent with setting goals of care. So you have to, but you can't take it on your own. You have to discuss with the relatives and set a sensible goal that is achievable, that's good for the patient, and the relatives are prepared for it. Goals of care should be addressed as early as feasible, but no later than within 72 hours of ICU admission. Thank you. Okay. Okay, this is my first class, so I don't know whether. Okay, I'm going to ask a question to Meghawali Jha. Hello? Okay, I don't know how this works. Meghawali, Rohan Gupta, anybody around?
Yes, sir.
Okay, hi. Did you understand
Uh,
everything I said?
yes, sir.
Okay, I hope you're fit and fine. Where are you?
Sir, I'm home.
Okay, keep your spirits high. Is there any questions you have? Any queries?
No, sir.
Okay, very good. I think Meghawali has left the laptop on and scooted off to enjoy herself, probably. Now I'm trying to see who all are there.
Yes, sir.
Okay,